Good morning. I am thrilled to be here with you guys this morning. Just kind of quick win for it behind the week. This week was a very busy week. I taught close to 30 hours out of my week was teaching my paramedic classes this week. And I'm just as excited to be in here with you guys this morning. So we're going to jump right into it. In this one, it's all shock, right? It's all about shock, all the different types of shock. And in terms of national registry, really the recognition of shock and the appropriate decision-making behind any treatments is just absolutely critical information for it. So I found this quote, I like it: obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out how to climb it, go through it, or work around it. And so really, it's Michael Jordan obviously talking, basketball and challenges in life and everything, but it's a very, I think, appropriate quote as it kind of relates to education and schooling and studying a ton for everything in your EMT program and trying to figure out how to succeed, how to pass tests, how to pass national registry, how to get jobs. All of those different kind of aspects that go into this is really just getting creative and continuing to find a way, right? That's really one thing that I believe in, is there's always a way, right? Matter of just finding it, right? All right, so jumping right in, like I said, it's all shock, right? So the other name for shock is hypoperfusion, right? Low perfusion. And so I really wanted to, kind of start it off with what is proper perfusion in the first place. What's the kind of textbook definition behind it? What's it actually mean for us? So I love just saying it's all about getting the good stuff in and the bad stuff out, right? We spend in EMS, we spend the vast majority of our time thinking about and talking about making sure we're getting the oxygen in. If they're not having enough sugar, let's get some sugar on board, right? But really, that's just one half of that equation. And it's very much a two-sided coin. And it's something that we have to at least consider as well. All right, so textbook definition, more or less, is circulation of oxygen, nutrients, and waste in adequate amounts to meet cellular needs, right? It's talking about each and every individual cell throughout the entire body is requiring appropriate amount of oxygen, appropriate amount of nutrients, primarily the sugar, the glucose that we spend most of our time kind of thinking about on the nutrient side, but then also the waste removal, right? So again, we have to be able to deliver that oxygen and sugar, but we also have to remove the waste products, right? Otherwise, those waste products will just start stacking and stacking and stacking up in our body, and it's just going to make us more toxic, usually more acidic. So it's really, it's that two-sided coin. It's really the best way that I can say it. We got to be able to get the good stuff in. We got to be able to get the bad stuff out. So in shock and perfusion and all of this stuff, the primary focus is on making sure that we're maintaining perfusion to the big three, the important stuff, right? Brain, heart, and lungs, right? Those are top three, right? Those are all geared at making sure we stay alive, and heavily focused on really making sure we're getting the good stuff in, right? So the oxygen coming in, our blood and our heart pumping it around, but then the ability to also get rid of those waste products. So we breathe out some of the waste products, right? Carbon dioxide is a waste product for us, so we breathe that out. The other kind of two, after the initial three, right? Brain, heart, and lungs, the next two is liver and kidneys, right? Liver detoxifies the blood, kidneys filter the blood, right? So those two organs are heavily focused on dealing with those waste products and how to get that bad stuff out of the body, right? But we spend, again, most of our time airway, breathing, circulation, right? Brain, heart, and lungs. But again, just right below that, next step down is how are the kidneys doing and how's the liver doing? Because they got to deal with the other half, which is that waste product removal. All right. So again, like I said, it's brain, heart, and lungs. And the goal is continuing to generate energy in each and every cell to stay alive, right? So each and every cell throughout the entire body needs oxygen, needs sugar, right? It needs one other thing that we're going to talk about here in a second too, right? It needs all of those things in order for that cell to create energy, for that cell to stay alive. And the cell right next to it needs oxygen, needs sugar, and it creates energy for that cell to stay alive, right? So it's a cell by cell by cell by cell issue that each and every single cell needs those things to stay alive, right? It has to create energy. Right? So in order to create energy, like we said, oxygen, sugar, and temperature, right? An appropriate temperature, right? It's the three main things, right? And the top two, oxygen and sugar, are the main ones for the energy production. But everything, right, and that whole homeostasis, balance inside the body, is all making sure that everything in our body is operating in an appropriate range, right? So everything has that. Right? Oxygen, we have a little range of oxygen that our body likes to operate in. If the oxygen's too low, it's a problem. Right? If it's too high, it can actually be a problem too. We don't really talk about that one too much, right? Called hyperoxia, right? Too much oxygen, right? Just like anything else, right? Too much of a good thing will eventually become a bad thing, right? Sugar, same thing. We have this little range. Too low of blood sugar, it's going to cause problems for us. Too high of blood sugar is going to cause problems for us. Temperature, another one, right? We've got that nice 98.6 degrees that we like to live in, right? Go just a little bit too low on that, we start to cause some problems in our body. Go too high, same thing, we can cause some problems. So we really have to make sure that we're continuing to deliver appropriate amounts of oxygen to our patient, check that blood sugar, right, and make sure that if it's too low, right, maybe it's an indication for us to do oral glucose, right, or rendezvous with ALS, or get them to the hospital, right? And then temperature regulation, right? We obviously have the extremes. If you go to like your environmental emergencies chapter, we have the extremes of, you know, severe hypo and hyperthermia, but ultimately, even just the basic stuff like putting a blanket over our patient as one of our shock treatment indications, right? Keeping our patient warm, just because if we go too cold or too high, but the tendency with shock is that we'll go cold, then we have to keep them warm, because otherwise other organs and things don't start functioning as well as that temperature in the body drops. So in the energy creation, the energy production, the outcome of all of that is making energy. Like we said, the good thing is making energy. And energy in the body is in the form of ATP, which is adenosine triphosphate. That's your kind of Jeopardy gee whiz knowledge bit for the day. It's ATP is energy production made in the mitochondria in each individual cell, right? If you go back to that huge anatomy and physiology chapter, and it spends a little bit of time usually talking about cellular anatomy. We don't, again, like in my classes, I don't test super heavily on in-depth cellular anatomy and physiology, just because I think that there's bigger picture stuff that we should be focusing on, at least focusing more of our study time and everything on. So the goal, like we said, the goal is create energy, right? So ATP is the energy, right? It's the energy in the body, right? One of the byproducts of our body using oxygen and using sugar to make that energy is heat production, right? That's why we're all walking around more or less 98.6 degrees Fahrenheit. It's a little bit of heat that's actually generated by all of the cells throughout the body that are going through this metabolism cycle to make energy, right? One of the things with the energy is making some heat, right? So we all warm up there. And then the main byproduct for us when we're utilizing oxygen appropriately in the body is we make carbon dioxide. Right? So carbon dioxide is the waste product of our body's use of oxygen. Right? So it uses the oxygen, uses the sugar, makes energy, and then the waste product is carbon dioxide. Right? And as far as waste products go, carbon dioxide is a pretty good one. Right? Because for carbon dioxide, all we have to do is keep breathing. Right? And that's the method that we have for getting rid of that waste product is breathing. Right? So even breathing is a two-sided coin, right? It's all about getting that oxygen in, but just as importantly is getting that carbon dioxide out, right? When we don't have enough oxygen, right? And this whole oxygen presence for everything is called aerobic metabolism, right? Aerobic meaning it's in the presence of oxygen, right? So like aerobic exercise, right? You're going for a nice long run, you got plenty of oxygen in your system, right? That's aerobic metabolism. Its main byproduct is that carbon dioxide. In anaerobic metabolism, right? We just jotted down here, anaerobic metabolism, right, means it doesn't have any oxygen, or it doesn't have enough oxygen. So instead of making as much carbon dioxide as the waste product, it makes things like lactic acids, right? If you've ever lifted weights, worked out too hard, and they talk about that lactic acid that has built up in your system, that's the waste product in that energy production cycle. That waste product, lactic acids and things, are much more difficult, takes a little bit longer for that waste product to be eliminated from the body. Right? That's why being in this nice, happy, healthy aerobic metabolism, plenty of oxygen there, the waste product, carbon dioxide, we can breathe it out. Everything is super good to go for us. All right, so the three variables for homeostasis, for proper perfusion, and then the flip side is a breakdown in one of these is what pushes us towards shock. So it's all pump, pipes, and fluid, right? These are the three things that we have to have appropriate amounts of or functioning properly for our body to stay nice and happy and healthily perfused, right? Where we're still able to move oxygen and blood and nutrients and waste products sufficiently throughout the body to meet those demands of the cells. So the pump is obviously the heart, right? Fluid is our bloodstream, right? They have red blood cells, the plasma, right? The little liquid water that's in there. And then the pipes are blood vessels, right? So if we have all of three of those functioning properly, that heart is able to contract and move blood forward properly, we're good to go, right? If we've got enough blood in our entire body, in our system, then that's good. We're gonna be all right. And then if our pipes can vasodilate or vasoconstrict, just depending on what the body needs in that moment or where the body needs blood in that moment, right? If the pump's able to heart, if the pump is able to function properly, pipes are doing their thing, we got plenty of fluid in there, then our body is going to maintain perfusion just fine. And we see that primarily by monitoring what is that blood pressure doing, okay? It's the big variable that we're looking at as we go into this shock progression, is how is that blood pressure doing still? Because the blood pressure is entirely dependent on the heart pumping properly, enough blood being in the system, and our blood vessels able to vasodilate or vasoconstrict as needed. And so any one of those three issues starts to have a problem, we're going to call it a unique type of shock. All right, so one of them, right, we said pump, pipes, and fluid. So talking about the fluid ones, I just think that one is probably the easiest. There's two main kind of more focused ones. Kind of generically, they'll say hypovolemic shock, hypovolemic, low volume, right? Not enough fluid in there. Hypovolemic is generally more or less the dehydration cause. Maybe they've been hiking out in the desert for too long, right? And they've been sweating a lot, losing a lot of that water, right? They're really massively dehydrated. It can push them that direction. If we say specifically that they've lost blood, then it would be hemorrhagic shock. And so hemorrhagic shock is a type of hypovolemic shock. Right? You don't have enough volume, you don't have enough fluid in the system. But usually they'll specify it a touch bit further and say hemorrhagic shock if they want you to be thinking along the lines specifically of bleeding. Right? So with all of the shocks, what we find is when we use the other term hypoperfusion, right, that something somewhere in the body isn't getting perfused well enough, then those cells, what's happening is they're not getting perfused, so they're not getting that blood flow to them, which means they're not getting that oxygen to them. So really it's a hypoxia-driven issue. And if we go back to the thing, you know, oxygen, sugar, and temperature, right? Oxygen is really the one that's driving this initially. And so the way all of these shocks work is something somewhere in the body, some cells, some tissue, some organ isn't getting enough blood flow. It's not getting enough oxygen. And so those cells start sending up a flare gun, you know, flare signal up into the sky sending it up to the brain saying, hey, I'm hypoxic, I need more oxygen, right? So whatever it is in the body, if you're bleeding out and your peripheral extremities are not getting enough blood flow, they're hypoxic, right? They start sending those signals up to the brain saying, dude, need more oxygen, help me out here, I need more oxygen. Once that signal reaches up to the brain's like, not enough oxygen? Cool, I know how to deal with this. All right, let's breathe faster, right? We don't have enough oxygen, so let's breathe faster to get more oxygen in, right? So one of the very first early shock signs that you'll see is that increased respiratory rate for basically all of the different types of shock, right? At its core, again, they're hypoxic. Something somewhere is not getting enough oxygen, so the brain immediately starts firing that brainstem to make us breathe faster, right? So that we get more oxygen into the system. And then right behind that, our brain says, okay, we're breathing faster, we're getting all this oxygen in, now let's pump our heart faster so we can deliver all of that oxygen, right? So again, these are kind of our classic shock vital signs for most all of the shocks, is an increased respiratory rate and an increased heart rate, right? And those are in direct response to hypoxia, again, to that hypoperfusion, right? Let's breathe faster to get more oxygen in, and then let's pump faster to deliver that oxygen. And all of those things, right, are trying to just stabilize our blood pressure, right? Because if something isn't getting enough perfusion, that's generally tied with our blood pressure is not sufficiently to pump enough blood there, right? For whatever the reason is, we're not getting enough perfusion, we're not getting enough pressure of blood going there. So all of this shock compensatory process that we're going to be talking about, all of it is geared at just trying to stabilize that blood pressure in this kind of critical emergent situation that the body is trying to figure out what's going on and how best to deal with it. First and foremost, we're like, let's just protect the blood pressure, because we have to make sure that we can maintain perfusion to the important stuff, brain, heart, and lungs, that's going to keep us alive in the first place. So again, just because of that hypoxia, let's breathe faster so we get more oxygen in the system, and then let's pump faster so we can deliver that oxygen. Another variable that comes in with these generally is vasoconstriction, right? If we vasoconstrict and we are trying to pump blood through smaller pipes, now the pressure of that fluid going through the pipes is much larger, right? It's much higher. So the analogy I like to say is if you turned on your kitchen sink, but on your kitchen sink you hooked up a fire hose, right? And so you turn on that kitchen sink full blast and you have a fire hose that's there. The pressure coming out the end of that big fire hose pipe would be a very low pressure of water, right? Just because of how big that pipe is. Right? Our kitchen sink's doing the normal thing. It's putting out the normal amount of water. Just that pipe is so big that the pressure is, very, very low at the end of it. Then the flip side of that would be hook one of those tiny little coffee drinking straws up to that same kitchen sink, right? Turn that kitchen sink on full blast. It's going to be shooting water out the end of that straw, right? A much, much smaller pipe increases the pressure, right? Again, the kitchen sink is doing what it always does. It's putting out the same amount of fluid as it always does, but because it's a smaller pipe, it's a higher pressure, right? So our blood vessels work that same way. If we have that vasoconstriction, it's going to be a higher blood pressure, right? If we have vasodilation, it's going to be a lower blood pressure. So our body is constantly making these adjustments as we try to maintain perfusion of the important stuff, right? The brain, heart, and lungs. Our body starts shunting that blood away. That's part of that vasoconstrictive process, is let's shunt blood away from that less important area. Right? And basically in that critical, what we say, the fight or flight response, right? In that critical fight or flight response, our body is all about survival, right? Everything is survival oriented for us. So with these, it's vasoconstricting away from the less important in the moment things. And so if you were running away from a lion was chasing you, for example. It's not a Tiger King reference. I actually haven't even watched that show, so I don't know. But say you're running away from a lion, right? And your body is amped up, stressed out. it's concerned, right? The body's like, okay, let's shunt blood away from your reproductive system. You don't need that right now. Let's shunt blood away from your skin. It'll be fine. It can go a while without good blood flow. We need to redirect that blood to the brain, heart, lungs, and our big skeletal muscles so we can run away. And so it's all, again, just shunting blood away from it, right? Away from the skin in this case. And so as we shunt blood away from the skin, that's where we get that cool, pale, clammy skin sign that shows up, again, in most of our shocks, because it's directly tied to that blood pressure as our body shunts blood away from the extremities to prioritize the core important organs that are going to keep us alive. As it progresses, right, if we're not maintaining that blood pressure at all, and we start going a little bit hypotensive, right, we're going to start losing perfusion to our brain, right, and that's going to push us into that altered mental status territory. We already said hypoxia is really a driving variable in all of these shocks. So cyanosis is a likely sign that you'll see developing. So these ones are all pretty much universal to most of our shocks, with only a couple exceptions that'll come up in this session. But other than those, specifically with these fluid problems where we're hypovolemic or hemorrhagic, another one that they like to give you that's very unique to it, and they'll phrase it this way, they'll say collapsed or flat jugular veins. So if you're looking at those big jugular veins that people have on the side of their neck, right, if they describe them as flat or collapsed, it's telling us there's not enough fluid in the system. And so if you ever see that one's kind of a good test-taking little nugget there, is that collapsed or flat jugular veins is almost definitively telling us that there's not enough fluid in the system. Whether the cause of that loss of fluid is dehydration or abdominal trauma and they're bleeding into their abdomen, or a external arterial bleed, whatever the case may be, is they don't have enough fluid inside their system. And so they'll actually describe it that way as collapsed jugular veins. All right, so those are the fluid problems. And then we'll do pipe problems. Right? So pipe problems generically are called this distributive shock. Right? Distributive shocks are all of our pipe problems. Right? So there's three main ones and a fourth little one that we'll talk about. One of them is anaphylactic shock. Another one is neurogenic shock and septic shock. Those are our main three that are distributive shocks. Those are our pipe problems. And if we think about in shock, our blood pressure is going down, then the pipe problem, if we're thinking it's either a vasoconstrictive process or a vasodilating process, in these distributive shocks, in order for our blood pressure to be dropping like that, it's going to be a vasodilation. And so all of these, we get widespread vasodilation, right? And that drives our blood pressure lower. Now, it's caused by different things, but they all result in a similar effect, which is that vasodilation. Now, sometimes I will say that they do use the term relative hypovolemia in these distributive shocks, and it's relative hypovolemia. They've not lost fluid. All the fluid is still in the system. If it was a fluid problem, it would be that hypovolemic shock or hemorrhagic shock. But in these, they say it's a relative hypovolemia. And if we had kind of our normal blood vessel, and our normal blood vessel had its normal amount of blood going through, and now we get widespread vasodilation, right? That same amount of blood is now filling up less of that blood vessel, less of that pipe. So they say it's relative hypovolemia, that the amount of fluid in the pipe is not sufficient relative to the size of that pipe. So if you ever see that relative hypovolemia, again, it's not that they've lost fluid, it's just they don't have enough fluid for the size of the blood vessels because of that widespread vasodilation. All right, so first one we're going to talk about is anaphylactic shock. And anaphylaxis, obviously, the cause is a widespread, life-threatening allergic reaction and some sort of allergen that the patient got exposed to, whether it's a bee sting or peanuts or penicillin or anything that they could be allergic to. It triggers basically an over response of that immune system, where how the immune system would normally deal with a foreign invader, a foreign antigen. The body does that, but it does it kind of overload, right? It goes crazy on it. It does it way too much, way too intense. And so you start to have the normal response, which is beneficial. And like I said earlier, too much of a good thing becomes a bad thing, right? So that heightened over the top immune system response is actually a negative thing. It starts causing too many problems. And one of the kind of big chemical part that is driving it for us that we talk about is histamine, right? In that allergic reaction, right, our body releases a bunch of histamine, or releases some other stuff too, like leukotrienes, but histamine's the main one we talk about. And that histamine, as that histamine is floating around through the bloodstream, that histamine has the effect of causing that widespread vasodilation, right? And that's why in allergic reactions, right, most of us have it at home, is Benadryl, right? And Benadryl is an antihistamine, right? It's blocking those histamine receptors throughout the body. So histamine is what's causing the problem. It's causing that big time vasodilation. So if we had a Benadryl as an antihistamine, it would help kind of work against that histamine inside the body. So our main signs and symptoms, again, we really see our same kind of initial 5 that we saw on our hypovolemic hemorrhagic shocks. Again, in this case, the pipes are too big, which means that pressure at the end of the pipe, right, all the way down to those cells, is too low. That pressure, that perfusion is too low. So those cells are sending up those flare signals to the brain saying, I'm not getting enough blood flow, I'm hypoxic. And like I said earlier, the brain responds by saying, okay, cool, hypoxia, I can deal with that. Let's increase respiratory rate, get more oxygen in the system, and let's increase our heart rate to deliver that oxygen. Right? So it's the same one, and then you as you progress, because that vasodilation, you progress to that hypotension, alter mental status, potentially cyanosis. That's that same progression, but the initial kind of core vital signs associated with these is trying to maintain blood pressure for as long as possible. And it does that with increasing heart rate and increasing respiratory rate. Now, some of the unique signs and symptoms that'll tell us anaphylactic shock as opposed to any other type of shock is if they give you words like urticaria or rash or pruritus. Right? Urticaria is hives. Right? Urticaria is hives, so those kind of raised bumps. If you've ever had an allergic reaction, or if you were stung by a bee or stung by a mosquito, and you get kind of that little isolated, swollen up, elevated spot. If it's just one, they call it a wheal. If it's a lot of them kind of throughout or over the body or over the trunk, right, wherever that allergic reaction is progressing, they call it hives, or the fancy textbook word for that is urticaria. And then pruritus is our fancy word for itching, right? So if you're in hemorrhagic shock, you're not going to be itchy in hives. Right? If you're dehydrated, you're not going to be itchy in hives. Right? If you're neurogenic or septic or cardiogenic, all these other types of shock that we have, if you have hives and itching, it's none of those. Right? That's the only time we talk about those is in the context of these allergic reactions all the way up through anaphylaxis, right, or anaphylactic shock. Also, you can get some edema, right? Some edema, some swelling. Right? One of the most concerning ones is that airway swelling. Right? If we have signs of an allergic reaction and airway swelling, we can immediately bump it up to that critical status of anaphylaxis. So we get that airway swelling. We know once that airway swells shut, we're going to be in real bad shape real fast. Right? So we have to deal with that airway swelling. If you get that big tongue that swells, right? Sometimes you see some pictures, usually a picture in your book, has that tongue is like really, really swollen out. They call it angioedema. Angioedema, write that in here. Angioedema is particularly that swollen tongue. And again, as that tongue swells up, it's going to block and occlude our airway. Then we're going to be bagging that patient, doing our best, doing rapid transport to the hospital, or hoping ALS gets here. So urticaria, pruritus, edema, angioedema are kind of those unique ones that'll tell you anaphylaxis versus, again, any of the other types of shock. Treatment for it, beyond our normal ABC management, we'll kind of talk a little bit more about those in a minute, gets us to or assisting with an EpiPen or carrying it if you work for an agency that stocks it and lets you carry it. In kind of national registry land, just run with the idea of we don't have standing protocols or offline orders because we're not working somewhere for a medical director. So in national registry, they say, call med control for everything but oxygen in terms of medications, right? Call med control for everything but oxygen. So EpiPens for an adult, and you can see it there on the box, the dose in the EpiPens for adults is 0.3 milligrams. For pediatrics, it's EpiPen Junior. They're usually stocked or filled with 0.15 milligrams. So it's a common doses that we see in our EpiPen and EpiPen Junior there. And that epinephrine, that's what's going throughout the body, causing the vasoconstriction, right? Helping deal with the histamine, right? So epinephrine is the wonder drug for anaphylaxis. It's the same drug that paramedics will give first for anaphylaxis. If you're in the hospital, it's the same first drug that they'll give in the hospital for anaphylaxis. It is the drug to deal with it. There's other ones that will come into play for it too, but first line is going to be epinephrine, hands down. It causes vasoconstriction, where, like we said, in this histamine release anaphylaxis, the issue is vasodilation. Right, so if we can give this medication that causes vasoconstriction, that's going to immediately help us. And epinephrine helps block histamine release inside the body. And so it serves kind of multiple purposes to help deal with the hypotension, but also to help deal specifically with that allergen that has been released inside the body and is causing our issues. So again, signs of an allergic reaction and airway swelling, we can call anaphylaxis. Or signs of an allergic reaction and hypotension, or sometimes they'll phrase it as cardiovascular compromise, we'll call that anaphylaxis. So if it's bad enough that our blood pressure is now dropping, anaphylaxis. Or it's bad enough and it's causing airway swelling, it's just real critical, so we'll call it anaphylaxis. So those are kind of some of the couple things. If you don't have the hypotension or don't have the airway swelling, then it really starts to fall off of that critical anaphylactic category to more so just a mild, moderate allergic reaction. And then we'll kind of shift a little bit in our immediate treatments at least. All right. So next up is neurogenic shock. Neurogenic shock is telling us that the issue is in the nervous system, right? Nervous system. So in these, the vast majority of the ones that we're going to talk about and the cause is spinal cord trauma, specifically high cervical spine trauma. So I found this picture of an MRI. You can actually see the vertebrae and see the spinal cord going down. It stops there and picks up over here. It's a complete kind of transection of that vertebral column. So very, very bad. But so that's most of the time is the issue is trauma, right? Just 99.9% of the scenario-based questions that you would get, if it's addressing neurogenic shock, it'll be in the context of a traumatic mechanism of injury. There are some medical complications potentially that could fit the classification, and actually they'll call it neurogenic shock. If it's a issue with like spina bifida, so spinal cord issue, it can result in neurogenic shock. But most of the time I want you thinking spinal cord trauma is what we're talking. So these, some of the same signs and symptoms, right? Something somewhere is getting hypoxic, so increased respiratory rate. But one of the hands down most unique variables that shows up sometimes in neurogenic shock, but it shows up every time in neurogenic multiple choice questions, is bradycardia, right? Bradycardia. All the other types of shock will respond by going tachycardic to try to compensate for it. So we said that's one of them, breathe more oxygen in and then pump faster to deliver it. In neurogenic shock, you may actually see bradycardia. Right? So you get this traumatic injury and you get an altered patient, they're hypotensive, your mind's going shock, but then you see a bradycardic, a slow heart rate. That should immediately raise a red flag in your head of, hey, this is different. I expect tachycardia in shock, so what's going on here? And the bradycardia associated with shock shows up in neurogenic shock. It's hands down. So that's the one that you'll see for it. Like I said, it's usually in the context of a traumatic injury. And then one of the other differences that you'll see is potentially normal or warm skin because it's associated with that vasodilation as opposed to the body shunting blood away from the extremities, and we get that cool, pale, clammy skin. And this, with that vasodilation, you're more likely to have normal, warm skin instead of that cool, pale, clammy, vasoconstrictive skin. And again, the process with this, or the problem with this, is that widespread vasodilation. And this time, the issue is because we cut off that nervous system signal, right? So the only reason why muscles contract is because it gets that electrical impulse from the nervous system that stimulates that muscle to contract. Right? So it's either going to contract or it's going to relax. Right? So when we get that signal from the nervous system, muscles contract. When we don't get that nervous system signal, muscles relax. And so what we have is wrapped around all of our blood vessels are little smooth muscles that contract or relax to cause vasoconstriction or vasodilation. Right? So if we just sever the spinal cord and we cut off nervous system signal to all of those blood vessels below that injury, and now they don't get that nervous system signal, all those blood vessels relax. And that's our vasodilation. Right? So because we actually vasodilate to our skin is why we'll get normal warm skin as opposed to vasoconstricting away from our skin where it'll go cool and pale and clammy. So you may see some skin signs difference with these distributive shocks where you may get some normal or warm skin as opposed to the cool, pale, clammy skin. But even more noteworthy in these is going to be bradycardia in our neurogenic shock specifically. Ultimately, for these patients, beyond our ABC management, spinal cord trauma, so backboarding, but really what they need is neurosurgery at a trauma center. Right, so it just emphasizes it that much more for us to go rapid transport and get this patient to the trauma center as quickly as possible. Nothing we can do pre-hospitally is really going to be impacting this when the issue is this high significant cervical spine trauma. All right, the third of our main three for distributive shocks is septic shock. So septic shock, our cause is a widespread systemic infection, right? So we get that infection into the bloodstream, right? And now we're just getting this circulated everywhere. And so what we see is the toxins, the bacteria, whatever it is that's floating around in our bloodstream, it starts damaging the walls of the blood vessels as they're floating by. And as it damages the walls of those blood vessels just get weaker and weaker and weaker, which is causing that vasodilation. Right? So weaker and weaker and weaker, you get vasodilation. This time it's caused by that infection, right? By those toxins, again, just poking holes and damaging the walls of the blood vessel. We see our same normal vital signs for shock: increased respiratory rate, increased heart rate, low blood pressure, progressing towards altered mental status, and then hypoxia. Unique to the infection side is obviously going to be fever for us, and the warm, hot skin associated with a person having a fever. Again, if you're in neurogenic shock, you don't have a fever. Right? If you are bleeding out, you don't have a fever. If you're dehydrated, you don't have a fever. Right? The fever is telling us infection, and the infection in the context of shock, we call it septic shock. So fever and warm skin, but fever is really that big one that's going to help kind of dictate that it's septic shock to us compared to any of the others. Treatment for these patients on the BLS side is all of these are recognition that your patient's in shock, and then rapid transport to the hospital or rendezvous with ALS. Anything else for septic shock is all about getting, the antibiotics specific to what type of infection they have, right? It's getting them to the hospital so they can get on those antibiotics. Right? If you have ALS that shows up, we'll try fluid, maybe some other medications, but again, still at its core is they have an infection, we need to deal with that infection. So we need to get antibiotics going for that person at the hospital. So fever is the big one that's going to tell us sepsis. But again, sepsis is widespread vasodilation caused by the bacteria and toxins just damaging the walls of the blood vessels. Now, usually what happens, we've been talking about all of these, it's either an issue with the pump, the pipes, or the fluid, right? Sometimes you can have multiple, right? We got to know which one is the main one. So in septic shock, the main one is a pipe problem, the vasodilation. But if somebody's septic, maybe they have been vomiting and diarrhea and not wanting to eat or drink much. So they may be dehydrated as well, right? They may be hypovolemic as well. But first on the list for sepsis is vasodilation. Secondarily, they may have hypovolemia as well. So again, remember, you can have multiples of these happening, right? In neurogenic, we could have that spinal cord trauma and they could be bleeding out. Right? So you may have multiple, but what's most important in kind of the initial pass of all of the shocks is understanding what's the main number one issue with that type of shock specifically. And then after that, what are the secondary things that you may see? Right. All right, so I said we were talking the three main distributive shocks, the anaphylaxis, the neurogenic, and the septic. There's a fourth one, just don't talk about it nearly as often. That's psychogenic shock, and that's caused by anxiety, sight of blood, needles, some sort of psychological trigger, and the body's response is temporary widespread vasodilation. Right? So that's unfortunately like me, if I have to get blood drawn or if I get a shot, there's like a 50% chance I might pass out on you. Right? I don't do well with needles pointed this direction. Right? I can start IVs on people, no problem. I do needles going that way, no issues whatsoever. But if it's coming this way, I get weird about it. I'm not proud of that one. I'm really not. But that's what it is, right? Some people, they see blood and they pass out. Now you're like, what happened? Right? I see blood, pass out. Right? Somebody throws up, they pass out, right? They just don't like it. It makes them queasy, right? Their body reacts, and in that reaction, goes boom, widespread vasodilation. And so just really suddenly just tanks that blood pressure. Right? Now, signs and symptoms are going to be kind of our normal ones, right? Because we get that widespread vasodilation, right? Our blood pressure is going to drop, respiratory rate and heart rate is going to increase. Potentially, though, by the time we get there, if we get called for this patient, and by the time we actually respond and get there, a 5-minute response time, patient's probably going to be awake, and the blood pressure is probably going to be okay already, right? So it's just that very temporary reaction, right? Usually, the person passes out, which is the body basically taking the psychology out of the equation, right? Just make you pass out for a second, so you faint, you have that syncopal episode, and then as the body kind of recalibrates itself, right, blood vessels constrict back down to normal, right, and then that heart rate and respiratory rate that was working to try to help us, right, usually maintains and gets that blood pressure back up pretty quickly as well. So kind of the unique part for it, we'd have to have some sort of history, story of an event, a trigger event, and they passed out after seeing a large needle, right, or they see clowns and they really don't deal with clowns and they pass out. There's some sort of history, some sort of story, some sort of event that happened that, oh yeah, they saw that, then they passed out. Like that's our psychogenic shock. And at its core, again, it is a vasodilation problem, usually just very temporary, widespread vasodilation. So different in its recognition from neurogenic, where we've got a trauma and it's not a temporary thing, right? We get this widespread vasodilation, then it just stays like that, because the body's not getting that nervous system input to try to vasoconstrict. So it becomes an ongoing vasodilation in neurogenic. Right? Anaphylaxis, until we deal with that allergen that's driving that allergic reaction, then it's going to keep staying in that vasodilation. Right? sepsis, same thing. Until we deal with that infection, it's going to stay in that vasodilation. So if they say what results in a temporary widespread vasodilation, psychogenic shock is the main one. Now, an important kind of side note caveat with this one is with psychogenic shock is the potential that when they had that fainting syncopal episode, did they hit their head on the ground? And now we actually have a trauma thing on top of it. Right, so make sure we're still doing our full detailed physical and just like, don't just be dismissive of it and say, oh, they just fainted because they saw blood, it's fine. Well, yeah, that's what happened, but maybe they hit their head on the ground on the way down and they actually have this other injury now going on with them. So we still got to do our detailed physical exam to make sure that we know what's going on with them. All right, and then last, so we've done fluid problems, we've done pipe problems, and now pump problems. And pump problems, we call cardiogenic shock. That's our heart's not pumping properly. And normal signs and symptoms for shock, right? Increased respiratory rate, increased heart rate, cool, pale, clammy skin as our body vasoconstricts and shunts blood away from the extremities, alter mental status, hypotension, cyanosis, those normal ones. Now, a very common one with cardiogenic shock is the potential that they had a MI or they had CHF exacerbation, they had some sort of cardiac arrhythmia, an electrical problem in their heart, some other traumatic injury to the heart or disease process going on in the heart, or chronic hypertension that's made the heart work too hard for too long, right? Something has now injured or impacted the heart from being able to pump properly and to keep blood moving. So if your heart's not pumping blood properly in the forward direction, that blood's going to start backing up somewhere. And you can go to last week's session that we did on CHF and to kind of follow through. If that left ventricle is not pumping blood well out to the body, then it's going to back up from the left ventricle to the left atrium and the left atrium into the lungs. And what we see is our pulmonary edema with the breath sounds that they'll describe as crackles or rails. It's the fluid bubbling inside the alveoli when we're trying to listen and that person's breathing. So these ones, a pulmonary edema might be one of the kind of pieces of the equation that would tell us a cardiogenic shock patient as opposed to anybody else. If it's in the context of MI or arrhythmias, they may have some chest pain associated with it. So a little bit, it kind of depends on exactly what's causing the heart to not work properly. But whatever it is, the actual issue is the heart itself is not strong enough. It's not able to pump well enough. So blood starts backing up. And usually that's what you see in terms of a unique variable to identify this one compared to the other ones is going to be the fact that you get the fluid backup signs like pulmonary edema potentially. So this one, the cardiogenic shock, really does go hand in hand with that CHF stuff from last week. So I would recommend going back to that video. And then the week before that was cardiac anatomy review. So it's been like kind of 3 in a row, the cardiac anatomy review, the CHF, and then this part about the pump problem, cardiogenic shock. Those 3 go hand in hand very well together. All right, and another, maybe the last other category that is a little bit unique in that it's not directly a pump, pipe, or fluid problem. It's mostly on the pump side, but in this case, in obstructive shock, obstructing means something is blocking it, right? So the obstructive shocks are the heart is not able to pump properly because something is blocking it from happening. Right, so there's 3 of them, right? Cardiac tamponade, tension pneumothorax, and pulmonary embolism, right, are 3 potential causes of obstructive shock, where in these cases, the heart itself, if we just isolated the heart from the entire body, just the heart, it's fine. The blood vessels can vasoconstrict and vasodilate just fine, and there's plenty of blood in the system still, right? So everything should be working, but something is blocking it from functioning properly. So cardiac tamponade and tension pneumothorax are the main 2 that you'll hear addressed most with obstructive shock. A little bit they'll talk about pulmonary embolisms as well, but mostly they emphasize the cardiac tamponade and tension pneumo. So in cardiac tamponade, what's going on is we have our heart, and around the heart is this fluid-filled sac, right, called the pericardial sac. Pericardial sac. Peri is around, cardia is the heart, and so around the heart sac, pericardial sac. In cardiac tamponade, fluid, blood, whatever it is, starts building up and building up and building up in that pericardial sac. And as that fluid builds up in that sac, it starts squeezing down on the heart. And so the heart starts getting compressed, which means it can't fill up with a lot of blood, so it's not pumping out a lot of blood. Right? Again, if we took that pericardial sac out of the equation, the heart would immediately go back out and it would be doing its job just fine. But with this swollen and large fluid-filled pericardial sac building up pressure and squeezing on the heart, that means we're restricting the amount of blood that can come into the heart, which means we're minimally pumping much blood out the other side. Right? So we're not sending much blood to the lungs, right? We're not pumping much blood out to the body, right? The blood is backing up, trying to get into the heart. So cardiac tamponade, again, fluid is filling up, blood is filling up that pericardial sac. So puts it generally slightly more in the trauma context for most of the scenarios that we'll see it, is that heart is damaged, the blood vessels are damaged, and fluid, blood starts filling up in there. It could be medical as well, it could be infection-based or cancer-based, could result in fluid building up in that the pericardial sac. But we see the classic shock vital signs: increased respiratory rate, increased heart rate, hypotension, cool pale clammy skin, cyanosis, all those normal ones. But then the unique pieces of it is what we call Beck's triad. I can't encourage you enough to memorize Beck's triad and to know what it's a sign of. So Beck's triad is specifically cardiac tamponade. And the three, right, triad is three. So the three signs that show up is narrowing pulse pressure. What that's the systolic and the diastolic on your blood pressure, those two numbers are getting closer together. Okay? So when we go hypertensive, both of those numbers usually go up. When we go hypotensive, your systolic and diastolic usually go down. In cardiac tamponade, your systolic's going down and your diastolic is kind of coming up a little bit. Right? So they get closer together. It's narrowing pulse pressure. Right? So if one set of vitals was 90/60 and the second set of vitals was 84/68, right? Systolic went down, diastolic went up. It's narrowing pulse pressure. Right? That's telling us between the high pressure contraction and the relaxation phase, right? The systolic contraction phase and the diastolic relaxation phase, is there's not much of a difference in those pressures, and it's because of all this extra pressure being squeezed on the heart in our cardiac tamponade. So narrowing pulse pressure is a big one. Jugular vein distension is another one. Again, this one goes back, it will look like our right-sided CHF, if you watch last week's video, where because of this pressure, we're not able to get a lot of blood into the right atrium, which means it's going to start backing up into the superior and the inferior vena cava. So the superior vena cava, as blood backs up there, that superior vena cava eventually branches and becomes your jugular veins, right? Or one aspect of your superior vena cava branches to become your jugular veins. So if we're backing up blood into that superior vena cava, we're going to start backing up blood into our jugular veins, and so we'll see that jugular vein distension that will show up. And then the other one is muffled heart tones, which gets talked about the least in EMS. But muffled heart tones would actually be getting your stethoscope out and listening to the bump, 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 bump of your heart beating. Right? The only way to really, or the best way to really be able to tell if they're muffled is to get used to listening to a lot of normal heart tones. And then you get used to hearing what normal is, then it makes abnormal stand out to you a lot better. Right? So muffled heart tones means it's actually diminished. It's harder to hear those heart tones. Right? And it's partially because we're trying to listen to it through a much larger fluid-filled pericardial sac But then also because the heart is very weakly pumping, right, we're only going to very weakly hear those heart tones. Right? And those heart tones are achieved by those valves inside of our heart snapping shut. Right? So when our heart pumps and those valves snap shut, right, that pump, that's what we're actually hearing if we're listening to our heart. Right? It's those valves hitting and snapping shut. Right? So if those are quieter, right, we call them muffled heart tones. That's the third of our Beck's triad. So that's very much the unique component of that one for cardiac tamponade. The next one is tension pneumothorax. Okay. Will show up initially the classic vital signs for shock: increased respiratory rate, increased heart rate, and hypotension. Unique about this one is obviously if we're talking about the entire chest cavity and we have, you know, our lungs in there, and say one of our other lungs got punctured, right? Maybe it's a gunshot wound or stabbing, something punctured that lung, and now the other lung that we have is releasing all of that air into this chest cavity. Right? And so we're getting this air pressure building up and building up and building up because that air is actually leaking out of the lung. Right? That lung has a hole in it. Right? So we're getting this buildup of air in the chest cavity. Right? Pneumo is air, thorax is the chest cavity. So pneumothorax is extra air is in the chest cavity that shouldn't be there. Right? So as it progresses and gets worse and worse and worse, and that air pressure builds up and builds up and builds up, it starts squeezing and compressing on that lung that already has a hole in it. It starts collapsing down. Right? So we get a collapse of that lung. So the unique part is the decreased or mostly what you're thinking, absent unilateral breath sounds. Uni is one, lateral is side. So absent one-sided breath sounds, right? So you listen to breath sounds, sounds great. Clear, good air movement. Listen to the other side, nothing. Listen back on that side, clear, good air movement. Listen on that side, nothing. Right, so we have one-sided absent breath sounds, tells us tension, tells us pneumothorax. Right? Once we say tension pneumothorax, it's really associated with that drop in blood pressure is the big one. Sorry, we have a bird here and our bird just went crazy. So we get absent breath sounds on one side, right? And as that air pressure builds up and builds up and builds up, kind of like cardiac tamponade, that air pressure starts squeezing on the heart and it starts restricting the blood coming into the heart and restricting the blood coming out. And so that's the obstructive nature, the blockage, right? In this case, the blockage, what's blocking the heart from working properly is all of that extra air that's building up inside the chest and squeezing on the aorta, squeezing on the vena cava, and squeezing on the heart, right? Really reducing that blood flow movement, right? So absent one-sided breath sounds. And then the other one that they like to give you a lot for tension pneumothorax is tracheal deviation, right? That's if we looked at it, or maybe we're palpating if we didn't immediately visually see it, and we've got our trachea as midline. Deviation is that trachea is actually pushed out to the side. And what that's saying is all of that air pressure that's been building up and building up and building up, that compressed on the lung and compressed on the heart, now is pushing all of that anatomy away to the side. Right? All of that air pressure is so intense and it's built up so much that that trachea is kind of like a focal point, right? It's kind of like a fulcrum. Right? So it starts pushing all of that anatomy, and as it pushes that anatomy, the trachea deviates away, right? So it deviates away from the tension pneumothorax side, right? So it goes to the good side, right? It's because that air pressure that's building up pushes everything away. Now the reality is that is a tremendously late sign of a tension pneumothorax, but it's a very classic sign that they'll give you in test questions, I promise you. Right? The tracheal deviation will be bad and it'll tell us tension pneumothorax. Or the hypotension associated with the absent breath sounds, we can call it tension pneumothorax. So again, relieve that air pressure, right? That's why paramedics are in the hospital. That's what we'll do is we'll put a big needle in there and release that air pressure. But if you take that air pressure out, the heart is immediately able to fill back up, plenty of blood coming in, get pumped out the other side, everything's fine, right? It's just that obstruction, that blockage of the heart from working properly because of the air pressure that's been building up and building up and building up. All right, and the last of the three, like I said, the other two are way more so, are obstructive shocks. I literally think when I was in EMT school, the pulmonary embolism wasn't even on the list for obstructive shocks. They kind of added it in a bit more. Again, in a pulmonary embolism, the issue is we get a blockage, right, a clot that got pushed into our pulmonary artery. Right? So that right side pumped a clot into our pulmonary artery, and now it's blocking, right, there's the obstruction, right, it's blocking blood flow to the lungs, which is blocking that blood from coming back to the left side of the heart, and the left side is what's pumping it out to the body, which is what we actually calculate our blood pressure off of. Right, so it's a blockage of blood in our pulmonary arteries. You kind of will see our normal progression towards shock if it gets that bad, with the respiratory rate, heart rate, all of those things as normal. The kind of unique pieces that will come up with pulmonary embolisms are sudden onset, sharp, pinpoint chest pain and difficulty breathing. So they say, my chest hurts, it's sharp, right here. It was sudden onset, difficulty breathing, right? And they can point with a finger to it. Right? On MIs, it's usually like, my chest hurts, just like right in the middle. It's kind of the squeezing pressure, right? Pulmonary embolism, let's say it hurts right there and it's sharp, right? Sharp, sudden onset, pinpoint chest pain and difficulty breathing. Right? So again, it's a good one to look at the progressive pain and the progressive pressure descriptor of that pain for an MI versus the sudden onset, sharp pain associated with a pulmonary embolism. Another bit that they'll tell you is hypoxia or cyanosis despite high flow oxygen. So if we're giving our patient high flow oxygen and they're still hypoxic and blue, they start to think, what's going on? Right? So we make sure that our oxygen tank is good. We're delivering plenty of oxygen. Right? We're checking our blood pressure. Blood pressure is okay. We're checking our heart rate. Our heart's pumping fine. That's all right. We're checking our breathing. Our respiratory rate is good. We're moving good amounts of air. We're getting good chest rise and fall. All of those things are good, but my patient's still hypoxic. That's telling us that we're having an issue with actually oxygenating that bloodstream. And in the context of a PE, that issue is we're not actually able to get that blood down to those pulmonary capillaries where that gas will exchange with the alveoli in our lungs. So that's the blockage. In this case, it's a clot that has blocked blood flow in pulmonary artery on the way to the lungs. So we can spend a whole day talking pulmonary embolisms, usually a little bit more contextual in some medical stuff, but you can see it in some trauma stuff as well. And if it's particularly severe, it can push them into a shock presentation. And if it is at the point that we're saying they're going into shock, then the class that it would fall into is obstructive shocks. And the last couple bits that I wanted to cover is the movement from compensated to decompensated to irreversible shock. Right? So those are the kind of progression of it, right? Everything's a scale. Are we early into shock or very late in the shock? Are we compensating for it or are we not compensating for it? That's a progression problem. So in addition to figuring out what type of shock am I in, it's also important to figure out, am I in compensated shock or am I decompensated or am I irreversible, which is really bad. So in compensated, that's where we're seeing our increased respiratory rate, increased heart rate, right? And if our body is able to, the vasoconstriction and shunting blood to the core. So we see that cool, pale, clammy skin, maybe delayed cap refill time. So remember, normal cap refill is less than 2 seconds. So if you squeeze on the nail bed and it gets pale and you release, and in order for that color to come back, it's 1, 2, 3, 4, and now it's back. right? It's greater than 2 seconds. We say that's a delayed capillary refill time. It's telling us we're shunting blood, right? We're getting poor perfusion to our very, very distal extremities. Other things that will show up is sometimes they'll actually call it early altered mental status changes, things like anxiety, restlessness, agitation. And it's that brain firing. The brain's not happy, right? We're septic or we're hemorrhagic shock, something's going on. That body is agitated. That body is irritated. So the person's a little bit anxious and restless and agitated. Some of that is secondary to hypoxia, right? Hypoxia can make you present like that. Some of it is the brain's just trying to fire to get us moving, right? To try to raise our blood pressure, do whatever it can to get us going a little bit. So that's when we say, we're compensating for it, is we're maintaining blood pressure. That's really the big one, is we're still able to maintain blood pressure. It might be on the low end of normal, but it's still in that normal category. So we're not hypotensive. So our blood pressure is still above, 90 or 100 systolic, depending on your book. And most of the time for EMT level, they say your blood pressure is maintaining at least above 100. Right? Some books will drop it back to 90, so always go back and reference what your book specifically says. In decompensated shock, though, now we're saying that vasoconstriction, that increased heart rate, increased respiratory rate, it's not enough. It's not enough to still stabilize that blood pressure, and now we're starting to go hypotensive. Right? So really that movement into hypotension is really the movement into decompensated shock, as we're not able to maintain that blood pressure. Another thing they can say is a weak or absent peripheral pulse. So if you know your patient's still alive, right, you got a pulse carotid, but you cannot palpate a radial pulse, that is most commonly tied to a systolic less than about 90. Right? So if you can't palpate a radial pulse, they're hypotensive. Whatever the number ends up coming out to be, it is what it is. But for most all of us adults, once you cannot palpate a radial pulse, it's telling us that our blood pressure is probably less than 90, which kind of back verifies that hypotension for our decompensated shock. Labored breathing, just as that body is really working more and more strongly and more hard to get more oxygen into the system. Remember, go all the way back to our hypoperfusion definition. Is primarily we're looking at it as not able to perfuse and deliver appropriate amounts of oxygen. Right? We said sugar and the other stuff comes into play too, but largely the oxygen. And skin signs, right? Maybe we're cool, pale, clammy. We start venturing into cyanosis or that mottled splotchiness or ashen or gray. Right? You really are starting to look, is visually looking at that person. They're looking in bad shape. Likely altered, right? Probably, progressing towards a fully unresponsive, but at least altered, confusion. That can show up a little bit in compensated shock too, but mostly in decompensated shock. We're really in that altered mental status territory. And then irreversible shock is really now the body is just about to go into cardiac arrest. Right? We're very progressed into this process. We've been, trucking along with a fast heart rate and a fast respiratory rate to try to compensate for it. And now those are also failing. And so usually everything starts slowing down, right? Our blood pressure is already down, but now the heart rate starts dropping. And now that respiratory rate starts dropping. Now everything in the body is giving up. And that's really that movement from now decompensated to even worse is irreversible. Is now likely unresponsiveness, probably bradycardia, slow heart rate, and bradypnea, slow breathing. So you really see everything giving up once you reach that irreversible territory. All right. And so last one here is again, just, recapping general shock treatment is ABC management, right? If we need to assist ventilations, we make that determination. Hey, you know what? They're shallow breathing. Let's assist ventilations, right? Using high flow oxygen with a non-rebreather or a BVM, maintaining proper temperature, right? So putting our blanket on our patient. So again, we said in that normal energy production in cells, one of the byproducts is heat. So as those cells start dying because they're not getting enough oxygen, they're not making as much heat. So all of us, we go hypothermic in shock. So we got to get that blanket on them and warm them up. Right? again, it's completely independent of environmental temperatures, right? It's not that they're hot or cold because they were outside or anything like that. It's internally, they're going hypothermic, they're going cold because those cells are starting to die and they're not making that energy and they're not making that heat as that byproduct. And really rapid transport, right? Again, I can't encourage enough in the national registry landscape for this type of stuff is recognizing that your patient is in shock and treating to the extent that we can treat them, manage their ABCs, keep them warm, high flow oxygen, but then rapid transport to the hospital or meeting up with ALS. We've got a couple extra options, but really it's get them to the hospital as quickly as possible. Anything else that we'll do is shock specific. Right? So if specifically we're dealing with anaphylactic shock, then we will do EpiPens. If we got them, we'll assist with that EpiPen. But most of them, again, it's ABC management, high flow oxygen, keep them warm, and rapid transport. Those are really the main ones for this stuff. All right, so like last week, I'm gonna do a couple questions and kind of use them to highlight some test taking stuff in addition to just contextually putting it into a format that you may see that would ask some questions on it. So I know there's a little chat bar, so you can jump into the chat bar if you want to answer it or if you have your 2 cents on it. But the question is, you are dispatched for a bee sting. Upon arrival, you find your 18-year-old patient sitting on a park bench. The patient states they're allergic to bees and hands you their EpiPen autoinjector. Right, the patient denies difficulty breathing. Vital signs of blood pressure is 126/72. Heart rate is 88. Respirations are 20 non-labored. And our SpO2 is 97%. You should A, administer the EpiPen after calling med control. B, perform a physical assessment and look for a stinger. C, begin assisting ventilations with a bag valve mask device. Or D, administer albuterol to help with airway swelling. All right. So the way this question, I've seen this type of question before. I know we have it in our test bank that we use in our classes very well, is, we obviously have this context of we were dispatched for a bee sting. We have a person that tells us they're allergic to bees and they have an EpiPen. So it really helps support that this person has a bad reaction to bee stings. If they've been prescribed an EpiPen, they're actually carrying it. What we have to figure out though is our patient in shock or not, right? That's really this question, right? Our mind immediately goes, and a couple of people have been jumping in saying, administer the EpiPen after calling med control. But remember, the indication for the EpiPen, the indication for us to give that medication is anaphylaxis. And we said for us to call it anaphylaxis, we have to be hypotensive, right? Or we have to have some sort of airway swelling, right? That's when they deny airway swelling, right? So even though we have dispatch saying bee sting, we have a patient saying they're allergic to bees, they have an EpiPen, we still have to do our assessment and determine, is my patient in specifically anaphylaxis? And if yes, then I have that indication now to administer or to call med control for authorization to assist with the administration of that EpiPen. Right? So in this case, I would say we have this person, they're sitting there, they're talking to us. Their blood pressure is 126/72, so that's good. And they deny any difficulty breathing. Right? So we're not getting any of our variables that are telling us anaphylaxis. Okay? So we're not going to call med control about that EpiPen. Okay? It doesn't mean this patient won't go into anaphylaxis, right? It doesn't mean that we're not going to transport them or that we're not going to end up giving them their EpiPen in the future, right? But just right now, just isolated to this question, we don't have a patient in anaphylaxis, so we're not going to administer or to try to administer their EpiPen. So another one, perform a physical assessment, look for a stinger. So again, we didn't get too far into really the allergic reaction stuff, but that one sounds okay. Begin assisting ventilations with a bag valve mask device. All right, well, we've got this 18-year-old breathing 20 times a minute, non-labored. SpO2 is 97%, and they've been talking to us, denies difficulty breathing. Doesn't sound like we need to bag that patient. We would need something like shallow breathing, hypoxia, cyanosis. Right? We would need some extra pieces of it to say that. Administer albuterol to help with airway swelling. So we can assist somebody with their albuterol SVN. This question, though, doesn't say anything about us having that. So for that reason alone, I would probably toss it out. And again, we have somebody that denies difficulty breathing, they're breathing non-labored, and their O2 sats are good. So, you know, as far as I can tell in this scenario, we don't have airway swelling. Right? And we're not going to administer albuterol for airway swelling either, but maybe we'll do a pharmacology day for another session. Perform a focus or a physical assessment and look for a stinger is a great one. Right? It really is the one that they say for these allergic reactions. If these bee stings specifically, if we're not at the point of anaphylaxis, if we are at anaphylaxis, then don't delay that phone call to get permission to administer the epinephrine, or that EpiPen auto-injector. But look for the stinger. The thought process behind that is when bees sting you, sometimes when the bee leaves or you flick it away or whatever happens, that stinger stays in place and there's that venom sac that's there. And so that venom sac can actually continue to inject more of that venom stuff in. And so if we see that there's still a stinger in place, they'll usually say get a straight edge, like a credit card or something, and scrape it off, right, to get that venom sac and that stinger out of there. So that's a good one for this. But I love this type of question just because a lot of students jump at it. They jump at that EpiPen because they see they're allergic to bees, got stung by a bee, they have an EpiPen, cool, give them the EpiPen. Right? But what they fail to look at sometimes is that assessment of their vital signs and presentation to figure out, are they in fact in anaphylaxis? And if they're not, then we don't have that indication to administer Epi. All right, another question here. Your patient was ejected from their vehicle during a car versus tree collision. The patient is supine on the ground, unresponsive, displaying decorticate posturing. We didn't talk about that one. Vitals, blood pressure 84/70, heart rate of 58, respirations 28, and shallow SpO2 87%. What condition are you most suspicious for? All right, so we've got a trauma. We've got this patient that's unresponsive, hypotensive, bradycardic, rapid shallow breathing. So this is one that our options are increasing intracranial pressure, hemorrhagic shock, neurogenic shock, or cardiac tamponade. And this is a great one just on the pattern recognition of the signs and symptoms that we're seeing will be how we identify this. So decorticate posturing, just side note, that's usually severe head, spine, high C-spine, brainstem trauma. Right, what happens is that patient just kind of flexes in to their core. Probably some of the easiest visuals that will mimic that you can see what that looks like is just go YouTube some like MMA, UFC fights. And sometimes you see those guys that get kicked in the head and they just collapse down to the ground and everything is contracted in. Right, that's decorticate posturing. Right, decorticate is everything is flexed in to the core. Right. The opposite is worse, decerebrate posturing, everything is extended out, and that one's even worse. All right, so on this one, right, we have hypotension, bradycardia, main ones, we have trauma, right? But really, this is the one that I said they'll bury it in a scenario like this that should raise a red flag, is so we see a hypotensive patient, we expect tachycardia, we expect a fast heart rate to try to compensate for it. In this case, we have a slow heart rate. So that tells us something. But if we worked our way through increasing intracranial pressure, one of the common vital sign changes that we'll see is an increase in blood pressure. Right? We have a hypotensive blood pressure here. In hemorrhagic shock, right, we have trauma, so 9 times out of 10 in trauma, we're assuming they're bleeding, right? So I like hemorrhagic shock just because it's trauma. But in hemorrhagic shock, we expect a fast heart rate because we're trying to compensate for it. We're trying to compensate for it. So we have a bradycardic heart rate. So I'm going to say, whoops, sorry about that. I'm going to say not that one. And then cardiac tamponade, right, we said can definitely show up in traumas as well. So sounds pretty good. 84/70 kind of sounds like a kind of closer together blood pressure. So I like that one. Cardiac tamponade, though, is another one that will respond with an increase in heart rate. And we have that bradycardic heart rate. So what we have here in this one is neurogenic shock. Again, altered, hypotensive. We have a shock-looking patient, fast breathing, right? Try to get more oxygen in the system. Everything is paint the picture of shock, but then they give you bradycardic, and bradycardic is a big one for that neurogenic shock. So I really want that one, again, to just kind of keep hammering home for you that our neurogenic shock is the one that has that potential to show up with the bradycardia. Right? Oddly enough, increasing intracranial pressure, that's another one we could spend a whole session on. Increasing intracranial pressure may have bradycardia, right? It may have that slow heart rate like that, but you'll see that high blood pressure, right? You'll see that high blood pressure for that one. So this is a good way to look at questions, right? A lot of times students, they like to look through the answers, trying to justify to themselves why one answer is correct. I like also doing the double check and flipping it around and saying, why is the other answers wrong? If you can rationalize why the other answers are wrong, then it helps support why the one is right. Okay? So if you say increasing ICP is wrong because that's a high blood pressure and we have a hypotensive here. Hemorrhagic is wrong because they should be tachycardic. Cardiac tamponade is wrong because they should be tachycardic, right? If you can give very definitive rationale justifications like that for why the other answers are wrong, then you're really sitting in a good position for why the other answers are correct. All right, and the last question on this one, in order to compensate for shock, the body increases production of epinephrine, which causes vasoconstriction, bronchodilation, and I put vasoconstriction in there as well, but tachycardia. Right? Sorry, I made a slip up on writing that question. Instead of having vasoconstriction twice, let's say tachycardia, right? Increasing heart rate. So vasoconstriction, bronchodilation, and speeding up the heart. This is known as the fight or flight response, which is an activation of the sympathetic nervous system, the parasympathetic nervous system, the somatic nervous system, or the central nervous system. And this one's mostly just kind of definitional, right? You're either going to remember it or you don't. But that fight or flight response is our, sorry about that, is our sympathetic nervous system. A couple people that jumped in on that one. Good job. Fight or flight is sympathetic, right? That's amping everything up, right? Parasympathetic is the other side of that. That brings everything back down, right? So in that acute emergent phase, our body gets amped up and excited. That's the sympathetic nervous system. But we can't all just stay walking around amped up and excited like that. So we have to have that system to bring us back down. So that bringing us back down is the parasympathetic nervous system. Okay. The somatic nervous system is our voluntary nervous system. Think skeletal muscles, right? The part that we have conscious control over. And then our central nervous system is brain and spinal cord, structure-wise. So I like to, I don't know what's going on here. All right, I like to, with the nervous system stuff, Remember, central nervous system, brain, spinal cord. And if it's not central, it's peripheral. So the peripheral nervous system, in terms of nervous system structures, is everything else, right? Brain and spinal cord is central, everything else is peripheral. Peripheral has, breaks apart, and it's either the somatic or the autonomic nervous system, autonomic. Somatic, soma is muscle, right? So that's our voluntary nervous system, right? Again, that's our motor nerves. That's we can have the thought that says, hey, I want to type this, and you engage muscles to type stuff, right? We have conscious voluntary control over that. That's the somatic nervous system portion of our peripheral. The other side is autonomic, right? And autonomic is automatic. Autonomic is automatic. So that's our involuntary nervous system. Good. Those are all the things that our body is doing without us having to consciously think about it. So the autonomic nervous system breaks down or separates into the sympathetic nervous system or the parasympathetic nervous system, right? This parasympathetic nervous system. So sympathetic, fight or flight, right? Everything gets amped up. Parasympathetic brings us back down, right? So fight or flight, a lot of people on sympathetic or parasympathetic, they will say feed and breed or rest and digest. Right? So we have fight or flight, and we have feed and breed and rest and digest. So just different body systems get controlled by each of those. So again, I like the sympathetic parasympathetic breakdown, understanding that that's under the umbrella of the autonomic nervous system. And autonomic is automatic, and the autonomic is part of that peripheral nervous system, is the kind of sub breakdowns of those categories. All right, and wrapping up here before I kind of open it up to any Q&A for a little bit. For study habit builder for the week, I like net time or no extra time, right? Is basically using and being prepared and using the little bits of time that you have available that everybody does, right? 1 year's 365 opportunities, right? We all have the same amount of time in our day to make use of. So it's making use of all that extra time, right? So whether you're driving, doing dishes, walking the dog, anything like that, you know, have your flashcards handy, have some videos handy, and don't watch videos while you're driving, but maybe you can listen to the audio of it, or an audiobook of your textbook, or these videos, when I upload them on my website, you can watch them again, listen to those, right? So it's really, it's making use of that. So instead of just standing there doing the dishes, listening to music, why don't you stand there doing dishes, listening to your audiobook, right? Or rewatching these videos, right? Or if you're waiting in line at a store, not right now because we're all social distancing, you're waiting in line at a store, pull out some flashcards, right? I uploaded it to my website that you guys have access to. In Quizlet, I built a whole lot. It's like a 227 slide deck of digital medical terminology flashcards. And you can just sit there and check yourself on flashcards, right? And just check, all right, do I know what that root word or what that component of a medical terminology word is? And you can sit there and check yourself, right? So it's really, again, it's making use of those. I do it all the time with podcasts and just trying to figure out, you know, learning more stuff and trying new things. So I really recommend kind of doing a time audit and taking a look at what are you spending your time on, and how can we make the most of all of that stuff, all of that extra time, right? So no extra time, right? Make use of it. Certainly in the context of EMT school, right? And I know some programs are very short, so it really puts a lot of pressure on time management, right? That's the name of the game. In paramedic school, I tell my medic students, time management is half the battle. If you can master time management, you're going to be in a great position. So part of that becomes maybe instead of watching Netflix for a couple hours at night, you do some flashcards, right? Or you find some videos out there, or you engage with me on social media, you know, shoot me some messages, ask me questions. I'll get to them, I'll answer them. So really, again, just capitalizing on your time, right? Making the most use out of it.